can see me okay? And you can see my screen? Yes, okay, very good. So yes, it did not go so well in December, so I figured we need a take two because I do have a lot to present. I'm very excited about my field and very excited for you and, shadowers to see what we do as endocrinologists and how we got here. Okay, so without further ado, I do have a lot of slides to share, so I'm going to start. Okay, so there, that's me. So key points to cover in this talk. So I want to tell you, so we're going to go back and forth. I am going to tell you about my journey, how I got here. I want to tell you about endocrinology. So there's going to be a few science slides. I want to show you what I do day to day in my life and private practice, what else I do besides seeing patients and doing clinical work. And also like a few pearls I hope that you guys pick up from my talk, and my hope is that I get you inspired to join in our, in the science, to be in medicine, specifically to be in endocrinology is such an exciting time. Okay, so how I got here, and this is something that could encourage. So I did my training in medical school in the University of the Philippines. So I graduated in 1998. And so it goes to show that I would say we all come from different backgrounds, and you don't technically need really to be in an Ivy League, pedigree to be successful. And so I did my MD, got that from the University of the Philippines. After I graduated, I came to the United States and I was accepted in residency in internal medicine in Southern Jersey. So the Jersey Shore was my haunt for 3 years. So it was Atlantic Care Regional Medical Hospital. Then after that, so I'm going to show you pictures. And so this was my scene from 1999 to 2002. So Southern Jersey was a community program. It was affiliated with Thomas Jefferson University Hospital and Hahnemann. Unfortunately, Hahnemann Hospital is now closed. So this was us in the cafeteria. This was my program director. This is one of our very senior attendings. These are co-residents. We had residents from all over the world: Kenya, the Philippines, Syria, Egypt, Pakistan. And so this is where I developed lifelong friends. I still call on them today. So it was a great time. I did not realize it. Of course, I had a real good case of what we call, that thing we call imposter syndrome. And so I wish I enjoyed it more, but I truly did. After New Jersey, I was accepted into the University of Missouri, Columbia for endocrinology. So one thing about endocrinology specialty is that these are very small programs. Typically, each program accepts only one or two for each year. So I think nowadays they realize the importance of building endocrinology in internal medicine, the subspecialty. So I think some of the programs are a little bit larger. But at that time that I was starting, 2002 and 2004, they only accepted one or two. And so I grew up in the city in Manila, Philippines. And then all of a sudden, so New Jersey was okay. I was able to go to New York. And all of a sudden, I was thrown into Missouri. And so it was a good time. I spent 2 years there. It was pretty good. So meaning it really also made me learn a lot about the culture, being in the United States, making friends. So this is my co-fellow, Candy Nobles James. She's from Georgia and she's back there practicing. And she's in private practice. This is Dr. Mugo. She's in Atlanta practicing as an endocrinologist. And so, yeah, this was my administrator. So I think she had Cushing's syndrome. She truly did. And then this is one of our attendings, Dr. K. She's from Bangladesh. So I have great memories. And so, again, what I wish I knew then that I know now, when you're young, you have to have courage because, I feel that you really don't know how bad can it get? To me, as long as you show up and do it day by day, as long as you show up day to day and just eye on the ball. So I think that you can make it in life. And so I really did have a lot of imposter syndrome, but in the end, what What's different about me, now I know, was the most special thing about me that makes me stand out. Um, and so that's the one thing I think I learned after, but it took me 10, 15 years to realize. Okay, so I want to pivot into endocrinology because there's a lot of science to share. Endocrinology is the science of hormone. Hormone comes from a Greek word that means impel or to set in motion a chain of events. Very beautiful subject. So these are substances or chemicals that are produced by discrete glands in your body that tend to be really small. I mean, these glands in the body are pea size or kidney bean size, but they're very active at producing hormone. They get thrown into the circulation and they circulate in your body, in the bloodstream. And wherever we have receptors, we are called target organs. And once the hormone sticks or sticks onto the receptor, then it sets a chain of events that starts to regulate your physiology and even behavior. So that's the reason why I went into endocrinology. Is the whole thing I thought was so elegant. Nobody seemed to understand. It seems so mysterious. People just say, oh, it's my hormones. But if you really sit down, there's such a very elegant rhyme and reason to it. Types of hormones, there are 4 types. So most of them, a lot of them are lipid derived, meaning they stem from our cholesterol molecules, and enzymatic changes make them into what they are. You have some that are amino acid derived. You have some that are peptides, meaning a chain of amino acids, and protein is a chain of even more amino acids. So these are all the typical hormones that we have circulating in our body 24/7 at each and every juncture. This is the whole set of hormones, and so we have all these little small glands that are in our bodies, and they produce all of these hormones. They communicate with one another, and this is, I feel that I wanted to take a little bit of time. This is the crux of endocrinology, is the feedback loop system. And in the outset, if you want to understand hormone, the only thing you need to know is do not be intimidated. They're just speaking with each other and getting feedback from each other. I mean, how beautiful is that? So to give you an example is the pituitary. So let's X the hypothalamus. Let's look at pituitary. The pituitary is located at the base of the brain in between the eyes. It's called the master gland. It produces a lot of hormones that regulate an organ. Okay, let's talk about pituitary and thyroid. Okay, and so you have a pituitary producing TSH, thyroid stimulating hormone, where this is the heater, the gland, thyroid gland, and pituitary is the thermostat. So therefore, your thermostat is telling your heater to, hey, start to produce hormone and deliver heat. So if the gland has gotten too much, or all of a sudden it's producing too much, it'll say, hey, I've gotten enough, shut it down. And so this, the heater, also tells the thermostat, I've gotten enough, you don't need to crank me up. So that's negative feedback. And once it cools off and it's not producing enough, this will turn it back on and say, hey, I don't feel anything, you need to crank me up. That is it. And so when we're interpreting thyroid blood work, that is the heater thermostat system that I'm talking about that we are kind of thinking through. And that is the same for growth hormone, and your liver producing growth factors is the same principle from your pituitary, and your testicles or your ovaries is the same relationship. And so if only we sat down and looked at these relationships and understand, that's endocrinology. So I think that feedback system really is the crux of, and it's not so mysterious. So once you sit down and kind of just think it through, it is doable. So then I'm going to pivot. These are the subjects that we treat and study, and in the field of endocrinology. One big field is diabetes, because after all, insulin is a hormone. Insulin is a hormone that is made in the pancreas. And so I'm going to tell you about, okay, what's exciting about endocrinology now? Blood sugars, how exciting is diabetes? Diabetes is so exciting now because We have spent the last 10, 15 years, 20 years, like doing all this research, and all of the fruits of research are just coming out, I would say, in this decade. So in terms of diabetes technology, I want to show you what the latest is on how we treat our diabetics. And so we now have continuous glucose monitors. In the past, you need to prick your finger 5, 6, 10 times a day to know what your blood sugar is. But now we have devices that you can wear that monitors your blood sugar or gets a reading from your subcutaneous fluid every 5 minutes, and therefore you're able to see what your sugar pattern is. What's interesting is because it's checking blood sugar so many times a day, I mean every 3 to 4 minutes, it's spewing out a result. Instead of just seeing what the number is, you also have an arrow. Is it 90 going up or is it 90 going down? I think this has really changed the way we treat diabetes. It's really made a big difference to a lot of people. So imagine if you're able to read your blood sugars as if you were reading your time. And the way somebody put it to me before is that in the past, you were driving your body with your blood sugars, but you were only opening your eyes every time you prick your finger. So imagine driving and you're just opening your eyes 3 to 4 times a day. So you're bound to fail. So now we have these instruments that we are reading your blood sugar as if you're reading your time. So therefore, you're able to pace yourself. So therefore, they even have data now that says just the mere fact that you're wearing these devices will make your sugar control better. So imagine controlling your blood sugars without even a medication, just because you know. So these instruments. So we now also have better insulin pumps. A pump also, do not be intimidated. A lot of people are intimidated by these devices. Pump is just a way, it's just a syringe of insulin inside this device. And this device is actually able to deliver this insulin in little bits and pieces during the day. That's it. But what's interesting is you have pumps that deliver insulin in minute amounts. And these pumps now communicate with the continuous glucose monitor. So now we even have algorithms and artificial intelligence inserted into that relationship. And so therefore, it's almost what we call automated. So if the blood sugars are going up, the pump delivers more insulin minute by minute. And if the blood sugar is going down, the pump delivers less. So we have more and more machines kind of racing to improve these algorithms. So we call it the automated pancreas. So these projects are actually driven by the JDRF. These are families of diabetics and type 1 diabetics who really want to move towards a cure. If we are short of a cure at this point, we want the best technology to be available for, to control blood sugars very well and control blood sugars safely without hypoglycemia. Okay, so in terms of the insulin world, so I also don't want you to be intimidated, even though this is scientific. So I want to show you like what kinds of insulins are better now. We even have better and better insulins. This is how your body produces your own insulin. So your body produces sugar 24 hours a day. So your body also has to spew out insulin to control it. Your body spews out insulin from your pancreas slowly. We call it the basal insulin. And so even if you're not eating, your body is spewing out sugar just because all of our cells need sugar to work. And so at the same way your body produces sugar, you need to also be producing insulin to keep it at range. This is your yin and yang. Okay, and so when we're eating, sugars go up, insulin needs to come out and bring it back down. So you have the base insulin that is produced from the pancreas, and you have a bolus insulin that responds to eating, breakfast, lunch, and supper. We call this the long-acting insulin, and we call this the short-acting insulin. Okay, so therefore, the medications that we have are all just a hash of this. We have short-acting insulin to help us with meal times. We have long-acting insulin that we inject daily that acts as our base. So in the past, we had insulins that really were not long-acting, they were intermediate. They peaked on you, they didn't last as long as they said they would, but then the insulins now, the basal insulins are much better, they're much flatter, and the short-acting insulins are quick in and quick out. So that's the research. So, but the basal insulin, sometimes when they say, oh, it's very steady, it actually is not. So as you can see, the green is a study on the newer insulins that we have now. And this gray is the older basal insulin, meaning they measured levels of these insulins after they were injected. They found that the older insulins really had a lot of variability because these were the amounts of insulin that were peaking and volleying in the bloodstream. But when you injected the new insulin, it really was steady. So variability is less. So even what we call better can be even better. So this is what we're doing in the field of insulin study. And so now, instead of the long-acting, we have even an ultra long-acting. So sometimes when patients forget their daily dose, like let's say you forgot a dose today, we don't tell this to patients. But we know that, oh, you still have that ultra long-acting, you're going to be fine. What's interesting is that these insulins do not stack, and it's a complicated pharmacokinetics. They don't stack, yet they last, but they don't cause a lot of hypoglycemia. Okay, so those are the advances, that we have even more stable insulins. The next is we have a lot of different hormones that can now treat diabetes. We are just not limited to, hey, sugar's high, give you insulin, drop it down. So we have found that when we are eating, we have more than just insulin that comes into play. Turns out when we're eating, there are 200 gut hormones that come out. And so those actually affect the way your body responds to that blood sugar. And so we have a new sets of medications now that help us control blood sugars and also help your appetite, help you not be so hungry, help the insulin be taken up nicer or more efficiently by the muscles. And so we have these groups of drugs called GLP-1 receptor agonists. These are one of the gut hormones. So how does it compare to insulin? This shows you that, for example, if you have a patient who is on pills and can't be controlled, what's our next step? So they compared their drug, Ozempic, with Lantus. Lantus is insulin. So what do you do next? When you start insulin, how much can you control it? When you start Ozempic, how much can you control it? So this shows when you are on Lantus or when you pick insulin, then you're able to reduce your sugars by the average by 0.9%. But with these new drugs, you're able to reduce it by more. And also what's interesting is because these drugs help your appetite and help satiety, instead of gaining weight with insulin, you're actually able to control blood sugars and lose weight. So 7 pounds and then 10.4 in a higher dose. What's interesting is you might not think as, pre-med or that this is a big deal, but this is actually a big problem for us because we've known for years that insulin kind of tends to make people gain weight. So how do you control blood sugars and lose weight? That's exactly what we needed to do, but we had medications that kind of made you disadvantaged and actually led to even more weight gain. Okay, so but now we're turning the tide. So we have those groups of medications. We also turn to the kidneys, and now there's another set of medications that helps your kidneys pee out more sugar, lowers the threshold. And so what's interesting is, okay, if my kidneys are helping me pee out the sugar, then of course my sugars are getting under better control. So, but it's also helping me pee out calories because sugar is calories, so it also helps me lose weight. Also, it makes me pee, so therefore blood pressure is better. So then that unloads my heart. So overall, my condition gets better. So we now have all of these medications that help us. So these new drugs have been out for only about 2 to 3 years, but they also help lower your A1C. These are all the 3 drugs that are out. Actually, there's 4 or 5. And along with controlling blood sugars, they help you lose weight. So these are comparatively, these are the 2 new classes of medications we have right now. So instead of weight gain, we control blood sugars with weight loss. And lo and behold, these drugs do not cause much hypoglycemia, meaning they stop working when sugars are normal. So that's also a big deal. And therefore, because you have medications that help you lose weight while controlling your blood sugars, Now, we have found that um, it's overall better for heart outcomes. Diabetes, we know, is a risk factor for heart disease. And so when we have something that helps you lose weight, then we also find that it is better for cardiovascular outcomes, meaning diabetics who take these medications have been found to have a lower risk of heart attacks, strokes, and death. So that is what these slides are, is presenting that these drugs lower the risk. So when you are, when these points are towards the left, it favors the drug, meaning lowers the risk of these outcomes. Okay, next we pivot to thyroid disorders. So what do endocrinologists do and how do we treat the thyroid? January is Thyroid Awareness Month. And so this is another big, so technically I probably treat 70% diabetics, sorry, 70% thyroid and 30% diabetes. Diabetes is treated by a lot of our primary care doctors. Only the difficult ones get sent to us, but a lot of people don't understand the thyroid and they get sent to us a lot. So now also, this is a subject that we almost our bread and butter, as you say. We have added other modalities, meaning endocrinologists now have ultrasound machine offices in our practices. And along with looking at the blood work, we are also able to look at the structure of the thyroid. So this is the windpipe and this is the thyroid when you're lying down. So right side, isthmus, and the left side. And we are able to visualize thyroid nodules. So it used to be the nodules had to be very large for your hands to feel them. But nowadays we're able to look into the characteristics of individual smaller nodules. And we do these procedures safely. So we have the probe, and when we need to biopsy a nodule, insert a needle, and we see the needle directly. Because it is now guided by these instruments. So this has also revolutionized the way we treat these conditions. So this is something that's part of my clinic day. I biopsy nodules on the same day. So typically I do, out of maybe 20 patients, I do 6 biopsies a day. So it's not that dramatic anymore, meaning it's not like a procedure that you have to come back for, prepare a lot for. This has really made things much simpler and more accessible. Okay, we also treat adrenal and pituitary disorders. So I kind of just wanted to see, kind of let you know how stealth these hormones are, that these patients probably had tumors or pituitary nodules or adrenal nodules that produce too much cortisol or steroid. And so these were before and these are afters once they're treated. So as you can see, Cushingoid is what we call it, or too much cortisol, round face, acne. And so it's kind of like what we call a plethora, and just feeling it kind of a look of maybe fatigue and just blah. And so but once these are found, these are very kind of very significant. You see you're able to help them significantly. And when they're normalized, it's really very gratifying to see. You have disorders of growth hormone, where these are very hard to catch, but you kind of need years. And these are comparing pictures before they are diagnosed. So typically it takes 10 years for these to be diagnosed because you're not able to see changes in features. And so growth hormone is, they make the skin look very thick, they widen your they make your bones grow, so they widen your nasal bridge, teeth. You can get gaps because the jaw is growing and lengthening. So these are also tumors or pituitary nodules that produce too much growth hormone. So also part of our treatment and things we always watch for. We also treat disorders of sex hormones, estrogen and testosterone. Of course, estrogen for females, testo for males. So we treat a lot of males who are deficient. So these are all the different preparations of testosterone. So we have gels that you can apply. You have injections that are done intramuscularly. We can insert pellets that release testosterone slowly. Now we even have oral So it used to be orals did not work because if you swallowed a pill and went through your and if it went through your liver, then it caused liver issues. But nowadays, they're finding ways of delivery that are safe. And so we deal with all of these medications. And of course, before we treat somebody with low testosterone, we always look to see, why is their testosterone low? Is it because your testicles can't make it, or is it because your pituitary doesn't signal your testicles correctly? So again, it's that feedback loop that we're always looking at. So we don't want to miss pituitary tumors. Okay, estrogen. So we overlap with our good gynecologists and obstetricians, typically gynecologists. So this is menopause. And so these are the typical ways we replace estrogen. We have the patches, we also have creams, we have the gel, we have a spray. Those are just examples. Okay, and then we go to, modern endocrinology. We have transgender medicine. So in the United States, I feel we have a lot of the doctors now really have good acceptance of and good command of transgender medicine and what transgender and gender dysphoria is. So again, these are people whose gender identity does not jive with their expressed sex. And so I also treat a lot of transgender people and gender dysphoria, so male to female or female to male, either way. And so we have good guidelines nowadays, which I think we did not have even like 15 years ago when I was graduating. So we have very clear guidelines now on what we are supposed to do. So first of all, we think that roughly 1%, 0.6% of US adults identify as transgender. So the more we do research on it, the more we find out. So I am an adult endocrinologist, so typically I don't see those who are younger than 18. So one of the guidelines says that intervention is reserved until after puberty is completed. So we treat with hormones to target a level that matches their gender identity. We typically treat in a multidisciplinary manner, meaning I always have them continue seeing therapists, or if they have other kind of mental health issues because of what they've been through, they see psychiatry along with them seeing me. And we also discuss fertility preservation before treating. So these are things that we all kind of treat day to day in clinic as part of our specialty. In my private practice, I also do a lot of clinical research. I'm director of research in my group. So meaning this is a way we give back and also contribute to the science moving forward. So we do a lot of studies on new insulins, new compounds that treat diabetes, and new compounds that treat, for example, osteoporosis and parathyroid adrenal disorders. And so basically what we do is we have this database of patients, and we are approached by pharmaceutical companies to recruit patients into later stage trials. And so they are randomly assigned to either control group or placebo versus the active drug that we are studying. And so what we do out as clinicians is we also have to supervise the staff, like my nurses, research coordinators. We take we take our database and we try to recruit subjects that meet criteria. We document, we handle the drug and make sure that it's well received and the temperature is right. We get subject to inspections and audits. So these are the day-to-day things that are happening in my practice. And so I'm also trying to be active in social media. So when you're a doctor now, it's not enough that you see patients. I feel that we also want to fight misinformation, especially in the world of hormones. So because it's subject to a lot of vagueness, maybe mystery. So there's a lot of people who try to take advantage by kind of selling you what we call snake oil. So we feel as doctors that, and that's why I'm here as well, that first of all, I want to fight misinformation. And so we have taken to social media to kind of promote ourselves. Not to me, it's not as much really growing patients because I'm already established. I've been in practice for about 16 years now. And so mostly for me is to try to continue to educate and dispel myths, and try to build camaraderie, and get to know other doctors, kind of like how we socialize nowadays. And so a lot of ethics, you know, we can see it both ways. We see a lot of people already coming to me, you know. So there are two doctors in the room. There's me, and there's that other doctor that's spelled Google. So they've already talked to Dr. Google, and then there's me. So, but you also have people who say, why are doctors in social media? You have probably doctors who have gotten very famous and have gotten kind of maybe askew, and ethics are being questioned. And so a lot of people don't think that this is the way to go. There have been there's this big controversy last year on doctors, current doctors being in social media. And there was a surgery journal that published some findings that young doctors nowadays don't know how to conduct themselves in social media. So they found that a lot of the doctors had unprofessional kind of behavior. But they defined unprofessional behavior as doctors wearing bikinis and living their lives. So there's that big controversy. Anyway, the paper was soon retracted, and this was a vascular surgery journal, so they published an apology article. So private practice, why am I in private practice? And so when I first came out of fellowship, really I was very comfortable being employed. In fact, I was employed for 5 years, but very quickly enough, I realized that this was not for me because I had no autonomy. Meaning my CEO told me that you had to take so much call, and you can't give those calls away because that's the way the hospital earned money. And so, but for me, I wanted more kind of independence, and so I chose to go into private practice afterwards. So I did not want to be beholden to executives, and so that's what I feel strongly about even currently. And I encourage you to maybe take our profession back, and again, do not undervalue yourself. And this is how we feel in private practice. So very difficult. How do you join private practice? Either you join private practice or you create one. So it is not easy, but I feel that the rewards are many. Okay, so I am in private practice, and I practice with one, two, three other doctors, and we also have a lot of physician assistants and nurse practitioners. So this is my crew. We're all about the same age. We graduated fellowship in 2004, and I feel very blessed and lucky to have found these guys and Dr. Addington. So that was from last year's Christmas party. No, 2 years ago's Christmas party. And so owning a practice, what does it mean? So we go to the nitty-gritty. We handle a lot, meaning we have a lot of staff that support us: manager, front desk, medical assistants, research coordinators, physician assistants, nurse practitioners, dietitians, diabetes educators. You know, we have to take care of how do you build a patient, contracts with insurance companies. We deal with patient complaints. We have to, you know, pay our rent or build our own space. Parking lots crowded. All these other things kind of are what we deal with in private practice. And so, in fact, when I joined my first week here in Fort Worth, I came from an employed position. Came here to Texas, and first thing I see in the bathroom is a scorpion. And so I come out of the bathroom and the restroom, and I go, we have to call environmental services. And I look around and I go, oh no, I'm in private practice, and whose environmental services is probably Dr. Lacken, my partner. So probably I need to go in and take care of that scorpion myself. So that was my first day, and first, you know, that's your realization that, yeah, it's kind of like your house and you deal with your own thing. We also deal with a lot of equipment We have all our computers, ultrasound machines. We have a bone density machine. We deliver radioactive iodine, so we get certifications for that. You've got your fax machines and all that waste management in your lab. So the things that I wish I knew, okay, so again, I have wrote over and over that what makes you different and the thing that you're most insecure about is I think the most special thing about you and what will set you apart. What I love about endocrinology is that yes, we're small. We used to be geeks, but we're trying to change that. And so what is the most different about us is the most unique about us. Yes, we're small, but we realize now that because there's so few of us, we are in demand. So it's not necessarily the worst thing about that specialty might be actually the secret sauce. So we had to look at it in all kinds of different ways. So yes, there's specialties that are more sexy, like surgery or even in the field of internal medicine, cardiology, you're a heart doctor. However, because so many people or so many doctors want to get into cardiology and the programs are larger, you end up being more saturated and there are more cardiologists or more surgeons that in the end it might not serve you well because there's so many that competition is tough. And so number two, wish I knew that I should have enjoyed myself more. But the biggest thing too is you have to have the courage to show up daily. And so you think that, oh no, it's 9 years or however many years I have to go this step and the next step. But you show up daily and that's part of your life. And in the end, you're done with it. So I feel that it's going to be okay. So you just pay your dues and you might be doing the scut work now, but it's not forever. Time will pass. And so now I am wanting you to see that me in the peak of my career, I'm in my 40s now. I would say life is good because I'm not a supervisor, I'm not a director. And so do not sell yourself short. But don't also be discouraged that when you're residents or when you're students, enjoy yourself, just take the time because that's your time to learn. So you have not much time to learn or to even read. You have to make that time when you're older. So it's okay. So also we have to take care of our finances. So I can't stress enough, live like a resident. We are the kings and queens of delayed gratification. So a lot of doctors, when you come out of residency and fellowship and all these years and years of study, you go, I want to reward myself. And you start buying big houses and big cars. And so, but we have to kind of pace ourselves because like we learned from coronavirus last year, sometimes some of the doctors get disadvantaged because then our incomes fell because we were not able to do elective surgeries. And so then it is still, I think, good to kind of don't upgrade your lifestyle too much. So we have to live like residents and we have to educate ourselves on how we can be financially stable. So I wish I knew that I had a plan. You have to start early, kind of looking at your savings and how you're going to plan your career. Because sometimes we never know, it might be short-lived. You don't have 30 years to have a long career, like somebody who didn't go into medicine and started saving when they were 23. So, and having a plan relieves anxiety. So another thing I learned is that family is very important. And so the same way you're doing this and learning and building your private practice, doing clinical research, you need to also kind of be there for your family. So I also learned from my experiences last year that, so much anxiety that I had family to fall back on. So either partners or kids or extended family, we need to make time for them. And then what COVID has taught me is that we need to be flexible. Instead of wishing for things to go away and for wishing the coronavirus to go away, life to be easier and get back to where it was, we need to do this. Wish for you to be better. So you take that opportunity. Sometimes the bad things are happening for us so that we are better. So then you cannot, your support system, I looked at my friends that I couldn't see, lean on your family, being your co-workers. And then being on your pets. I can't believe how much our pets have helped us. And you also need to diversify. Being doctors now, we're not sure whether incomes are really very stable. Last year taught us that. So sometimes we need to pivot and look at other things. And yes, so that's my presentation. I hope it was helpful. And I am just very thankful I got to the last slide. And so I'm on IG. If you can do something for me today, I'd love for you to follow me and continue to look at my journey.
Thank you so much, Dr. Tan. This was
Yay, we got to the last slide. Thank God. My God, no hitches.
If you open up the chat, you can just see like all of the inspiration and the thank yous that are coming in. People said this was the best presentation they've seen and that it was worth waiting for since December. So thank you so
much. Yes. Okay, oh no, hold on. Okay,
yeah, there's tons of people saying, yeah, that it was totally worth it. And thank you also for explaining in detail so much. And also there was a comment earlier when you were talking just about the basics, about how you should definitely host something on Khan Academy because you explain everything so well and in detail. So it was really
I don't know how to do that. You guys had to help me.
Yeah, so thank you so much for that. We did have a couple questions that we can go through. First one that a lot of people were asking is if you could just kind of touch on imposter syndrome a little bit, and some people don't even know what imposter syndrome is, so if you could just kind of explain that.
Imposter syndrome, you know, I use that a lot. I have to read up on what exactly it is. It's meaning you are in medical school, for example, you are in residency, and for example, me, I came from a foreign country, landed in the United States in a residency program. So first of all, you doubt, are they serious? They hired me. And what? They paid me money to come here. And so meaning you feel like you're an imposter or you stole that position from somebody else and that you are not worthy. So that's the biggest I feel that's the biggest definition. And so you almost feel like you're not worthy, you're not good enough where you are. And so a lot of us feel that, especially immigrants. And especially those maybe who didn't finish medical school or you didn't come from pedigreed degree, Ivy League degree. So that seems to be what everyone's talking about now. You know, especially when you're high school, you need to get to a Harvard or a Yale to be somebody in life. But I don't find that to be true, and I tell my kids that. And when they say, "Oh no, it's the end of the world," say, "Excuse me, I came from the Philippines," So therefore, you never know how you're going to get to where you get to, again, as long as you show up. So that's imposter syndrome.
Great, thank you so much. There was also a question earlier too, just asking about as endocrinology is more specialized than some other specialties, could you be working in more academic institutions, or is it more common to be in private practice?
There are both. Actually, more endocrinologists like being in academic settings because it really is a very scientific field. A lot of research going on, a lot of things changing. And so when you're in a university, actually, you kind of get inspired to be a university professor yourself. And so I would say maybe it's 60% academics, 40% private practice, or not affiliated or professors.
Great, thank you for that clarification. There was a really good question asking, what are currently the biggest barriers that you see in your patients in endocrinology, like cost of medications, racial inequalities, things like that, and how are they being addressed?
All of the above, meaning we are all, before we are endocrinologists, we are internists, or we are doctors of 18-year-olds and above, doctors to adults. So we face, so the biggest problems that I see in the field of endocrinology now is, okay, you've got all of these new drugs, great. You got continuous glucose monitors, all this technology, great. But the next question is, how are we going to afford them? And so these are made by drug companies who want a profit, and I kind of can't blame them. Who else is going to do research? The NIH cannot pay for the world's drugs. And so these drug companies kind of have that goal in mind, is to make a profit in the entire system. You have insurance companies who also want to make a cut out of those profits. And so all of them are trying to profit off of those drugs in patients. So I think access is the biggest issue for my patients. I can go to town telling them what the latest greatest is, but I did not help them if they did not get to actual, picking up the drug and taking it. And so that's why I think I also decided to go into clinical research, is because if I could get to the newest things and I could give them some access temporarily, maybe studies that are a year, 2, 3 years in length, so I can give them those drugs for free. And so I think access is one of them. And I think there are also few endocrinologists. Few endocrinologists means that, there's just so few of us to go around. We cannot get to you. Like the appointments sometimes take 3 months to fill, or 3 months for you to come be able to see us. So that's also a difficulty. Another is sometimes the internet. Over promise, under deliver. Always selling testing that is inaccurate. Always selling, this is good for your thyroid. And those can actually harm. So selling you adrenal gland extracts that contain animal gland. And so we don't even know what animals. And are those animals safe? Are those animals diseased? Is it pure? And so what if the animal had hypothyroidism? Yeah, so all of the, it's pretty challenging. But that's why I invite a lot of people who are interested. So to consider these smaller specialties, because this is where the need is.
Yeah, thank you so much for explaining that for us further. We hope that these issues will start to be addressed more in depth and solved soon. So we'll see with the new wave of endocrinologists, hopefully some who have been converted here. Another question that we had was, how often do you see DOs going into endocrinology? Is it something that's common? Is it more difficult?
Very common, meaning my partner, Dr. Bajaj, is a DO. So over here in Texas, we have a DO school here in Fort Worth, and I don't think we treat them differently or see them differently. It's the same.
Great, thank you. I know a lot of people have that question always about MD and DO, so thank you for that. This was a really good question. Yesterday, we had a session with a lifestyle medicine doctor who's also a physiatrist. And so she talked a little bit about the holistic approach about targeting patients, and especially for like conditions for type 2 diabetes. And how it can be effective and often overlooked. Is that something that you incorporate in your practice, like trying to focus on something other than just the medical approach to treating diabetes, or is that something that is more based for lifestyle medicine?
Yes, so for sure, we are also all about prevention, and so. And we cannot stress enough the virtues of good lifestyle, good diet, and good physical activity efforts. And so typically we think that should be a given. That should really be a given. And then if you are here, it's understood that you have done that. So, but you're correct. So the reality is a lot of people have other pressures. So to me, actually, the first thing I was taught in fellowship is we had this culture as doctors of blaming the patient. You did not do it. You didn't check your blood sugar. You didn't inject the insulin. We told you to do this much. You only did this much. But so if you started to blame the patients for not doing their things, you're doing them a disservice, because you did not work to see like what was the problem. Well, a lot of it's financial, and number two, the drugs were making you gain weight, And then you're telling me that 10 years later, there's a new drug that doesn't make you gain weight. And you're telling me that the insulins are better, that it used to really cause me to crash my blood sugars. And so there are many things like this where we say, oh, it's not their thyroid, or oh, you're just a cop out, something like that. So even with blood sugars, but there are so many things that it's either, yes, it could be you, the patient, you're not trying, but could you be really depressed because you have a life situation, you have systemic racism, can't get a good job. There's so many factors. So I think if we as doctors took the blame away, so I invite everybody, lifestyle medicine, as long as evidence-based. We do have a lot of, those in the realm of lifestyle and integrative that have good evidence behind them. So I'm all for it. But if there's anything we can do to remove blame from the patient and see what more we can do, I think we'll all be better.
Thank you so much for explaining that. Definitely very important to know. There was a really interesting question asking about hyperthyroidism and why patients experience the bulge in eyes, just out of curiosity.
Okay, so the bulk of thyroid disease, so what makes your thyroid go hyper or hypo? What we know is an autoimmune condition. So the same way your body produces antibodies that fight the outside world, it may make a set of antibodies that are attracted to your own organs. So the most common is autoimmune. Where does it come from? Typically it runs in families, and beyond that, I don't know where they came from, but they came out. So they recognize your thyroid, they stick to your thyroid, and those antibodies start to either block the production of hormone because they cause inflammation, or there's an antibody that when it sticks to the thyroid, it activates it. That's called Graves' disease. So it's the antibody that activates your gland that causes you to be overactive or produce too much hormone. What's interesting is that that same antibody also gets attracted to eye muscles. So when that antibody circulates and gets into the eye muscles swell up, and that's the cause of the bulging. So that's called thyroid eye disease. Actually, there's a new medication for that now where they block that receptor so that those antibodies can't keep activating those receptors. And then they help the eye disease or the bulging recede.
Awesome. Thank you for clarifying that and answering that question for us. There's another really interesting question that I liked asking about, if you could speak a little bit about the diversity in endocrinology. I think like racial and also gender diversity and kind of what you have noticed in the field.
I would say in that fellowship picture, that I showed you, and that was in 2004, I had Kenya with me, I had Macon, Georgia, and so I would say what's interesting is because endocrinology is a non-procedural specialty, less U.S. graduates are known to apply in them because the U.S. graduates want procedural specialties like cardiology, where they can do cardiac cath, or GI, where they can do colonoscopies. So I would say endocrinology is pretty diverse. So I have a lot of foreign graduates in, and of course, when you do medical school, also a lot of people, the competitive specialties are, I think, surgery and dermatology, radiology, anesthesia. And so I would say endocrinology, the smaller specialty, is more diverse. So there's no issues. In fact, when you look at the picture of my private practice, I have one Caucasian lady, me, Asian, and two are Indian, and one is Indian Hispanic. Indian from India.
That's great. That's good to know. A lot of people were wondering, so we're glad to see that representation. I guess the last question that we have for you as we wrap up is, what is the last piece of advice that you would leave us pre-med students with, college, post-bac, in this trying time of the COVID-19 pandemic?
It's not happening to only you. That's what I tell my daughter. She's 18, senior. It's not only happening to you, it's happening to all Americans, it's happening to people in the world. So I would say we're all in this together. Again, you try your best because we have nothing else to do. We are trapped in here. So you take this as opportunity. What else can I do? How can I better myself? Again, do not wish for it to go away. It's not going to happen. So you wish for you to be better while you're dealing with it. And how am I going to come out of this? So that's really the best the best to change your mindset. It's happening for you. You know, I mean, I don't want to wish that I also wish it goes away, you know. I want to get back to my life, but there are things about it that are good. I'm not pressured to kind of dress up so nicely anymore. I got time. I don't have to put on too much face makeup. I don't have to put maybe eye makeup. So no, they're good things. I'm not pressured to. I'm an introvert. I don't have to travel to conference anymore. That is so hard. So people seem to accept that we can do a lot of things remotely. And so I didn't have to spend too much money. Got closer with family. Got forced my teenagers to stay at home. And so there are also good things about it. But don't wish for things to go away and for it to be better. Wish for you to be better.
That's great. Thank you for the incredible advice. You are awesome. We